Yeah.
Excellent.
Oh, it will be?
Fabulous. Oh, yeah, yeah. I just hit record so that we can send it to him. Well, we're a tiny but mighty group, and we are recording it because I know there's some of our Doughnuts and Theology folks who are out doing various other things. But I'm grateful to all of you for being here and for Phil being here. I mean, is it 3:30 a.m.?
Not quite that early, 5:30. So
5:30. Okay, that's right. Burton, you said it would have been 3:30 if we would have done our usual Doughnuts and Theology.
Yeah.
Okay, fine. That makes me feel better. Everyone, I'd like you to meet Phil. Phil, do you want to make your screen big just so we can see you for a second? Like
sure.
see your face in bigger form.
Hang on, let me stop sharing. Oh, let me figure out how to do that. Hang on. There.
If it's too different. Okay, we can see you for a second. President Phil Verhoef may or may not be related to someone in the front row.
There are days we claim them.
Yeah. He's a physician, medical educator, researcher, and healthcare activist from Honolulu, Hawaii. And you can see with his background, I'm sure you're actually on the beach, right?
Yeah, if only.
Phil's going to be giving us an overview of both the U.S. healthcare system and the public health infrastructure in our country, and will be talking with us a little bit about what it means for us as Christians. So, Phil, I'm going to hand it over to you, but can you hear everybody okay? You can kind of hear a few of us in the room okay?
I can, yeah.
Okay, good. It just let us know if you can't hear us. We can hear you really well, so as questions come up, we can repeat as needed. So thank you.
Awesome. Well, it's really a pleasure and an honor to be invited to talk with you folks. You know, it's a little bit like taking the conversations that I have with my dad and just opening them up to more folks. But for better or worse. You know, this is, you know, it's it's interesting because, you know, one of the things that I've been doing, I've been working as a doctor for about 20 years now, and my specialty is intensive care. Um, but over the years, I've also gotten really interested in advocacy and in thinking about the system that we have and the system that we deserve. And you'll see in the bottom right corner there, it says Physicians for a National Health Program. So as a spoiler alert, I advocate for healthcare reform along those lines. I wasn't really going to focus on talking about that today. I want to just talk a little bit more about what our healthcare system has in it, as well as a little bit about the public health system and about some of the ways that that's being sort of, well, I don't know if it, restructured under the current administration. And then I think the discussion I really am interested in having is how do we frame this? How do we think about healthcare as Christians in this country? And where do we sort of put our values? And so let me go back to sharing my screen. Go. All right. Hopefully you can see that. And so I'll move forward. I'm going to be objective, but it's hard not to be political. I don't think that's a problem, right? I think you can make a strong argument that Jesus was political. And I don't think any discussion around these lines needs to shy away from being political, whatever you think political means. My goal is to educate and stimulate discussion and get us to think. And I welcome any and all questions that you might have, especially if you disagree with me, because that always makes for the most fun discussion. And I think a point to consider as we go through this, should the healthcare system that we have be focused on value, or should it actually reflect our values, right? And what are those values? And do they play out in the way that we take care of people? And so I often start with this. This was a headline from the middle of the pandemic. You know, pandemic or not, America has the best healthcare in the world, which is a belief that people often have. And I'm not sure I agree, right? This was a graphic that the government actually produced to illustrate our healthcare system. But to me, it illustrates how insanely complicated everything is. Like, look at this. You've got a zillion different bubbles, and you've got doctors and agencies and all kinds of things that are baked into this that are just ridiculously complicated. And I'm not sure that that's the best thing. And in fact, it's certainly not the cheapest thing, right? So when we compare how much we spend on our healthcare system in this country compared to other developed countries, you see we pay more than everybody else per person. And this is even older data. We're up over $13,000 per person now. That's almost double the next country down, and that's Switzerland. And so, that certainly should give us pause, right? That we're spending a tremendous amount on our healthcare. Now, let's take this a step further. We pay more per person than anybody else in the world, but what do we get for that? Maybe not much, right? So according to the Commonwealth Fund, they go out and evaluate healthcare systems and health systems in countries, and we're kind of ranked dead last there, as I think you can see compared to 10 other countries. And I think if you look at a metric like infant mortality, our deaths in the first year of life per 1,000 live births are higher than any of these other countries. But look at our life expectancy. It's actually lower than any of these other countries. And we're talking about a range of countries here. Nobody holds Costa Rica up as a highly developed country, and yet you live longer on average if you live there than you do in the United States. And so, looking at this graphic, this is one that looks at life expectancy at birth over time. And for the last 50 years or so, you can see life expectancies have gone up. The rate of rise in the United States has been less than everybody else. And then when everybody had a fall off in the pandemic, we just kept falling. We haven't recovered at all. So I think that I think this is an indication of that there's something wrong, something wrong either in the way we deliver healthcare or the way we structure our public health. And, people often say, well, maybe it's our own fault, right? But in fact, that's not the case. We don't smoke more than people in other countries. Man, look at the French here, man. 1 in 4 people are smoking. Those guys are really living their best lives, or not. It's not that we have more people who are over the age of 64. You can see the Japanese, almost 1 in 3 are over the age of 64. So, these are people that you typically think of as costing more to provide care for. That's not the case in the United States. We also don't spend more time in the hospital compared to a number of these other countries. Their average days per person per year in the hospital is higher. So that's another highly expensive place where healthcare can be seen. We're not going to the doctor more often. The average person in the United States goes to the doctor 4 times a year. Again, boy, look at that. Japan, that's probably why they have 1 in 3 people are over 65, because they're going to the doctor on average every month out there, right? So, that's not why things are worse for us or more expensive for us. And I'm going to make an argument that perhaps the biggest uniquely American source of spending in this country is actually within the private sector. So all of these countries, their spending is largely within the public sector. The federal government for these countries provides the funding for health and healthcare. And in the United States, a sizable proportion of what we spend actually is within the private sector. And as a spoiler alert, it's really within the private insurance system. And so that private insurance system for healthcare is really, you have to remember what their sole objective is. It's not to make people healthy, it's to actually make people money. And so let's think just a second about how that gets done. So in this country, you are a person, and maybe you have a job, right? Or you go to school and you work. And it is through this mechanism that you get health insurance, right? And you might get health insurance from any one of these various and sundry companies. And I think this is an important point, that you can't it's very hard for you to get health insurance as an individual. The vast majority of people get them through arrangements with their employers or their schools. And then you have these companies who set up contracts with physicians or with hospitals or with pharmacies. And then if you want to see a specific doctor, you have to make sure that your health plan has that doctor in their network. Or that hospital is contracted with that insurance company, or that pharmacy is contracted with them. And all of these things effectively get between you and your healthcare, right? Where this is your hospital, this is your pharmacy. there's all these other steps that get in the way. And that kind of complexity is, one, not necessary, and two, a huge burden on our country. And this is one of my favorite slides to show, comparing a major academic medical center in the United States at Duke with about 1,000 beds, and at the University of Toronto in Canada. And Canada has a national health insurance system. So in effect, they have a system sort of like Medicare, but it covers all of the people that live in Canada. So they don't have this sort of complicated private insurance system that we have. And if you look at the Duke Medical Center, they've got 1,600 billing clerks, more than one person per bed to help manage interfacing with those insurance companies. But if you look at the University of Toronto, they have 7. And those, you know who those 7 billing clerks are for? They're for Americans that go to Canada and end up getting their health care. It's not actually for the Canadians that live there, right? And you can do the back of the envelope math on this, right? 1,600 excess people at $100,000 a year. Now you're looking at, let's see, let's put 2 zeros on there. You're looking at an additional, $1.6 million just borne by the Duke Medical Center alone per year of expenses. No, that's more. It's 1.6 billion, 1,600 times 10, 1,600. Anyway, it's a lot of money, right? You can do the math on how much excess is spent. And this is a really compelling slide as well. When you look at the rise of physicians in this country compared to the rise of other people within the healthcare system that are not physicians, we've been outpaced substantially. The docs have, and so I think again, it's important to look at how this spending comes from. When you think about per person spending on healthcare, just insurance overhead alone is over $1,000 per person, and that overhead, that's money that an insurance company uses for profits. It's what they use for advertising. It's what they use to sort of keep the lights on. But all of these other countries, they don't have nearly that much overhead expense for the way they structure their health insurance. And again, I'd say, how does an insurance company make money? By collecting your premiums and then finding every way that they can to not incur a loss, and by not covering care that they're contractually obliged to cover. Insurance companies actually call money that they spend reimbursing you or reimbursing the hospital, they literally call that a loss, and that's calculated as the medical loss ratio. And I think that's kind of wild, because they don't want to lose money, but like their only job is to pay out when you get sick, right? That is literally their sort of raison d'etre, right? So let's think about some of the ways that they do that. They do things like requiring prior authorizations for procedures or medications. And that means that before you can get that MRI, your insurance company has to say it's okay. But I think this hurts patients because it delays you getting care, but it also hurts doctors because we have to fill out all of this paperwork and interface with these companies. That's our time that we're not spent actually taking care of people. It's just us being on the phone to get the care we think people need. But insurance companies also use narrow networks of doctors and hospitals. You can't just go see, any doctor you want. They have to be often in the network for the insurance plan that you have. Formulary design, if they don't want people with complex diseases, they simply don't cover those drugs, right? So as an example, if some insurance plans take HIV drugs and put them in the highest copay or the most expensive for patients to get those meds. And when you do that, a patient with HIV will simply look at that insurance plan and say, I don't want to get that insurance plan. That's not going to cover the medications that I need. And so, you can create ways in the drug coverage that you have to basically keep sick people from getting your insurance plan. And then they engage in denials of claims, whether or not those denials are legitimate, right? So you might have seen a headline like this: America's largest health insurer denying care with AI that's wrong 90% of the time. They don't care if they're right or wrong. They're creating a barrier to you getting care, and that means that they get to keep that money. So they're incentivized to not actually cover things, which I think is I think is problematic as somebody who, is involved in trying to deliver healthcare to people. So, that's private insurance, but I want to talk a little bit about Medicare since that covers 60 million plus people in this country. And you might know about Part A, which covers your inpatient, skilled nursing facility, hospital care, or Part B, which covers outpatient and doctor's visits and preventative medicine care. And these things are paid with what we call fee for service. And that means that the doctor sees you and then submits a bill to Medicare, and then Medicare pays the doctor back. You go to the hospital bills Medicare, and Medicare pays the doctor. That works pretty smoothly. And then for some folks, they have what are called Medicare Part C plans or Medicare Advantage plans. And this is paid where instead of the government paying to the doctor or the hospital, this is where the government pays a private insurance company to manage your Medicare. So it's really a different arrangement where you continue to have a private insurance company that manages your Medicare by getting money from the government. And we won't get into too much detail about this, but it's a system that is, I think, pretty flawed as well. And then, of course, the Part D plan for outpatient prescription drugs. Now, I want to contrast Medicare a little bit with Medicaid. Medicaid is the program that we have for low-income individuals and families, right? So Medicare is really only for people over 65. Medicaid is for people that are below some arbitrary income limit that the government sets. And like I mentioned, Medicare covers, Part A, Part B, Part D, and then there's Part C. Medicaid just covers everything, basically. You don't have all these different alphabet soup of parts. And for the most part, if you have Medicaid, you don't have to pay extra out of pocket for your health care. And you can get enrolled at any time. And so, that's administered on a state by state basis. So the benefits and structure can vary widely. And so this is good, right? These are safety net programs that the government runs. And for many people, Medicaid is, well, at least better than nothing. So we've seen our enrollment in the Medicaid program skyrocket, right? We're up to 90 million people. That's almost 1 in 4 people in this country depending on Medicaid for their health insurance, which means they're depending on a government program. And so any cuts or changes to Medicaid are going to affect a whole lot of people. And in some respects, you could argue that it helps. This was a fascinating study that they did in Oregon a while back, where they compared people. It was a randomized, it ended up being a randomized controlled trial because Oregon had too many people that needed Medicaid. So they had a lottery and some people got it and some people didn't. And, it's kind of a wild idea, but they were able to see that the people that got it were more likely to get mammograms or pap smears, or less likely to have depression, more likely to be taking medications if they were diabetic. So, it does help some, but in another study that was done, this was one of these cold caller studies where the researchers would just call up a clinic and they'd say, "Hey, I broke my leg. I need to see an orthopedic surgeon." And the first question they ask is, "What insurance do you have?" "Oh, I have Medicaid." "Oh, well, only 1 in 5 people could get an appointment for their kid who had Medicaid who needed an orthopedic surgeon. But if you had private insurance, you could almost always get an appointment, right? And if you have Medicaid and you need psychiatric services, good luck with that, right? Asthma, to see a pulmonary doc, or ENT, it's much harder to get care because specialists simply don't take Medicaid as an insurance program. And I think to myself, gosh, what good is having Medicaid if you can't actually find anybody to take care of you? So we've created an insurance system that doesn't actually do anything. And so that's Medicaid. But maybe you do have private insurance, but the problem is you have what's called underinsurance. And that means that you're still on the hook for paying too much out of pocket. And what we're finding is the amount that you got to pay when you go see the doctor is going up year after year after year. The average deductibles that people have to pay before their care kicks in just continues to rise. But the problem is, people think, well, we need you to have that deductible because that means that you're not just going to go get care willy-nilly. But this was a study where they took people that got shifted into plans that had higher deductibles than their prior plan. And you know what happens? they didn't go to the doctor. They stopped going to see, they stopped going to the emergency room. They were less likely to go see their doctor in the outpatient setting, less likely to get preventative care. So this notion that people should have to pay some out of pocket because it gives them skin in the game, I think that's a messed up notion. This is another example of a barrier to you getting care that the system creates on the false premise that you're going to overuse it otherwise. And so this notion has been disproven over and over again. And so we have all these things baked into our system that are actually hurting people. And let me just tell you, these things don't exist in other countries. And so that's uniquely American. And the problem is if you've got a high deductible, most people can't afford to pay these kinds of deductibles when they get care. This is the median assets that people have. Even 50% of people have less than $20,000 socked away for when they get sick, right? So that's like half of America. And so when they get sick, they get bankrupt. And interestingly, most of the medically bankrupt have insurance at the time that they get sick. Almost 2/3 of people have private insurance, another quarter are uninsured. And so, again, I ask, what good is having insurance if it doesn't protect you from financial ruin, right? And so I would argue that there's some real problems in the way that we've structured this system in our country. Of course, medical bills are the reasons that people get sent to collection more than anything else. It's medical bills, right? And while Americans are going bankrupt, you can see that there's sort of rampant profiteering going on in the country. There's for-profit hospitals, there's private equity groups that are buying up hospital systems and then bankrupting them, the pharmaceutical industry, the insurance industry. Honestly, I have like hour-long talks on all of these things, and we're not going to talk about any of that today. But I think it's an important lesson to look at that within this country, we have sort of worshipped at the feet of maximizing profit within the healthcare system and not maximizing care. And I think that that's really messed up. So, if we talk a little bit more about Medicare, I'd mentioned this concept of Medicare Parts A and B and then Medicare Part C, so-called Medicare Advantage. And if you ask people comparing them, do you like your Medicare or do you like your Medicare Advantage plan? The vast majority of people are happy with both. They think that the system works pretty well, which is good, right? This is a fairly recent survey. And I think that that's good, but I think there's more to that story. So in traditional Medicare, you get your Medicare Part A, you get your Medicare Part B, and then that allows you to go see whatever hospital or doctor you want. If you want to go across the country and go to the Mayo Clinic or the Cleveland Clinic, they'll take your Medicare, and that's not a big deal. You can kind of see, as long as you can get in and get an appointment, you can see whoever you'd like. But in the Medicare Advantage system, because they've inserted another private insurance company in there that runs those programs, that gets in the way. That creates that additional complexity. That creates limitations on your ability to access care. And so these companies do things like, have small networks of doctors. The 11.7 million Medicare Advantage patients are in networks that include most of the doctors in their county. They use things like prior authorization or, things to attract healthier people because they don't want sick people. They want people, they offer gym memberships because that if you can go to the gym, you're probably a little healthier. They have high overhead costs, high profit costs, and their expenses are much higher than those for traditional Medicare. You say, but they provide some hearing, some vision, some dental benefits, right? And those are the things that people most often point to as being good. But those things are not quite what they seem. When you compare the actual out-of-pocket spend for people with traditional Medicare compared to Medicare Advantage plans, they're not really saving you very much money for what they're providing, right? So you say you're still on the hook for all of these additional costs based on the way that we built our healthcare system. They use a lot of prior authorization. 83% of the appeals that in Medicare Advantage get approved, which means that they're inappropriately using prior authorization. If you have to always be appealing, and then they always get approved, then they probably shouldn't have been denying them in the first place, right? So I think when you look at outcomes, people that have Medicare Advantage plans, when they get cancer, it takes longer for them to start treatment and this is literature for all of these different cancers. And frankly, they're more likely to die after having cancer surgeries under these kinds of plans. And so, again, I'm sort of trying to drive home the point that we have created an insurance system that is really focused more on finding ways to profit and not ways to optimize care delivery. And so I come back to this massive bit of complexity that we saw earlier on, and really this very much still exists. And we know that we now have a Secretary of Health and Human Services in Robert F. Kennedy Jr., and he oversees all of this, right? This is all under his purview right now. He covers the CDC, the NIH, the ASPR, the Indian Health Services, the FDA, and he's had some pretty sketchy ideas about healthcare, not really understanding the difference between Medicare and Medicaid, making some sort of racist comments about COVID, wanting to create registries for autistic people, and honestly, wanting to disrupt everything in the scientific enterprise. So I'll take just a moment to talk a little bit about this, right? So what are some of the things that we've seen? The administration's looking for waste, fraud, and abuse. You hear that a lot, and that's governed by this document called Project 2025, which they called the Conservative Promise. This has been the blueprint for the actions we've seen in the federal government right now. And one of those things is to make Medicare Advantage the default enrollment option. And so I've talked to you a little bit about how Medicare Advantage spends more money, how it is harder to navigate, and how it leads to poorer outcomes. We don't really know what they mean by making this the default enrollment option for all people on Medicare, but we evaluated the implications of that just to see what would happen if everybody that had traditional Medicare got shifted into a Medicare Advantage plan. And if that happened, you'd have, 24 million seniors in this country would be in a physician network where they could only see fewer than 30% of the docs in their county. So that's hard for them to get care. And for clinicians, the time spent on prior authorizations would rise to 43 million hours per year, right? Based on how much we have to do with these plans now, which is, a pretty insane waste of our time. But I think it also would waste our money, right? Because Medicare Advantage plans actually cost more than traditional Medicare. This is how we pay for Medicare in this country. We have this thing called the Medicare Hospital Insurance Trust Fund. All of you, when you work, you get some part of your paycheck gets deducted and goes to covering this. And, it's working okay. There's money in the bank to take care of people with Medicare. If we immediately shifted everybody into Medicare Advantage programs, we would start to be in the red. We would be in deficit spending where we start losing money from this trust fund so that by 2027, 2020, I guess by 2029, that trust fund becomes insolvent. And so it's not a financially responsible way to approach healthcare for people. So of course, why in the world would they want to promote that? Obviously, it's for their profits. Other things that we've seen in this Project 2025, all of the things that you're hearing about now, these attacks on Medicaid, where they want to add work requirements or time limits or, have more co-pays for people or making it harder to qualify. And all of these things I think will hurt people because again, Medicaid is partially covering care for up to 90 million Americans in this country. We've got attacks on gender-related care. And whatever your opinion is on this, I don't think it's a good idea to not train people in giving abortions because whether or not, because because I guess let me just say abortion care is health care, right? There are times when when people need to know how to do that. And so, literally saying that this is something that we're not going to allow people to get trained in, I think is really irresponsible. Other things they called, at the beginning, you might have heard that there was Medicare had the ability to negotiate drug prices. That's actually been repealed. And I know that there was some in the news lately about a new plan for trying to cut drug costs, but if you dive into the meat of that, there's really nothing to it. There isn't really any power that the president has to make that happen. I want to talk a second about research in this country. We have the NIH, the National Institutes of Health, and that funds the training of researchers, basic science research, clinical trials, vaccines, cancer treatments, all these things. And I will say they've invested well over $1 million in me over the years. So the NIH helped pay for me to go to medical school because I was in a competitive program that the NIH funded. The NIH has been responsible for I ran a research lab where we were looking at, I was using mice to study infections. This was all part funded through NIH research grants, and it helped make a difference in the world, right? This is the discovery of new knowledge to help discover new treatments, new therapies. This is what the NIH does, right? And by one estimate, every dollar invested in the NIH generates $2.46 to the in economic activity in this country, which is a pretty huge investment. NIH funding is critical to the infrastructure of all of our universities in this country that have anybody that's NIH funded. That there is money from the NIH that supports the function of those universities, and all of that's currently being dismantled. And you say, gosh, what's being dismantled? They're cutting discovery of these novel therapeutics. There are literally clinical trials being shut down. There are labs that are closing down where people are, getting rid of valuable reagents, valuable supplies, but more importantly, researchers are just leaving the field because they don't have a way of funding their research anymore. And I just think the consequences of that are going to be, well, significant down the road. I mean, we are eliminating the training programs for the next generations of scientists, and it all seems to be done in a very politicized fashion. I have, some of my friends who have NIH grants, everything is fine, but others have lost all funding, and it's arbitrary and it's based on political decisions, and I think that's terrible. And then we'll shift gears to public health. We have probably the flagship organization in this country that handles public health is the CDC, the Centers for Disease Control and Prevention. And so if you've ever heard of the Hot Zone or Contagion or Outbreak, these are movies that you can see the CDC in action in them. They're the ones that respond to these kinds of disasters. And they cover really all things public health. You often think about them as infectious diseases, but they're also involved in environmental threats and injuries, chronic diseases, the opioid epidemic, gun violence. All of these things are things that the CDC studies, advises on, and tries to provide best practices for folks and help us understand public health in this country. They respond to threats, they provide guidance, and their funding provides the vast majority of funding for state health departments. So in New Jersey alone, the CDC provided over $500 million of funding to help support your public health department. My wife is our state epidemiologist here in Hawaii. About 85% of her budget comes from CDC grants. And so when the CDC gets dismantled, then she's losing a lot of funding to be able to hire the people that she hires to do the work of running public health in this state. And so, who's been let go? Well, everybody that tracks lead poisoning is now gone. They're not at the CDC anymore. They've actually let go people that are working on measles, which seems crazy when measles is at a higher rate of rise in this country than it has been in 30 years. There was a Center for Chronic Disease Prevention and Health Promotion that's been totally dismantled, which seems strange to me because I know how much that the current administration wants to talk about making people healthy again. The Maternal and Child Health Global Health Program, this has been cut. NIOSH, this is the National Institute of Occupational Safety. That's just gone. All of those people are gone. So these are the decisions that have been made in the current administration, and I think it's at the very least it's not even penny wise pound foolish. It's penny foolish too because these things are going to cost this country so much money, and so they've prioritized fighting illegal immigration. How does that play into the healthcare debate? Well, interestingly, if you look at immigrants, they don't get very much health care for lots of reasons, right? Either they're healthier or they're afraid to get health care. But as a whole, we spend much less on immigrants than we do on people that are born in the United States for total health care in the emergency department, their kids. And interestingly, when immigrants get jobs, they pay taxes into that Medicare system but they don't ever get to use it because it's not designed for them. And so they end up funding these programs like Medicare and not being able to benefit from it. They also the same holds true in private insurance. If somebody who's an immigrant gets a job and pays for health insurance, because they're so much less likely to use that health insurance, the insurance company makes money, whether you're a documented or an undocumented immigrant with health insurance. And so, and then of course we find immigrants in vital roles across the board in this country. So I think that this notion that we should be targeting immigrants is also going to come back to bite us in the rear ends as well, which I don't think makes a lot of sense. And so, I'll summarize a little bit here. I've talked at you for about 30 minutes. And that leaves us some time to have a little bit more discussion. But I think our U.S. healthcare system is dominated by forces of financial self-interest and not the interests of the health of people. And because we have this private insurance system, depending on the free market, we have so much more waste than in any other country. And yet things are only going to get worse. And I would say that the cornerstones of the U.S. federal government's involvement in public health, in science, and in healthcare are being and have been irreparably gutted. And I don't like this. I think this is problematic. I see this as hurting us. I see this as hurting science. I see this as hurting progress. And I think that that's not right. Now, you know, I think the first thing I'll pause for is, before we get a little bit more into the discussion is, do you have questions? And if this were a normal talk, I might tell you what I think are all the solutions, but I actually don't want to talk about solutions today. I think that I can, but I think that there's just more to unpack here as we think about the implications of all of this. So I'll pause for a sec and see if folks have questions about the stuff that I've just talked about. Yes, sir.
So first of all, I just have to say, it's an excellent talk. And I was a practicing internist doing primary care for 38 years. I retired last year. And every single fact you present is 100% correct. In some ways, it's even worse than what you said. Just two quick points I want to make. One is, primary care in this country is dying, as I know you know. And there was an article just in the New England Journal, a little perspectives piece called Primary Care Death by 1,000 Cuts. And there are many reasons why people aren't going into primary care. But one of them is the paper load burden and the number of things that insurance companies require signatures on. I mean, there's other things, EMR, a lot of other stuff. But basically, all this extra paperwork doesn't go to the specialist typically, as you know, it goes to the primary care doctors, and the doctors are burning out and they don't want to do it. And so that's a problem. The other thing I just wanted to mention to kind of piggyback on what you said about Medicare Advantage plans, I always told my patients, if you can afford it, do straight Medicare. That's my advice to you.
You mean a supplement?
No. I'm talking about, that's if you have regular Medicare, you get a supplement for the 20%.
Yeah.
These are people that instead of doing regular Medicare with a supplement, they do Medicare Advantage. Yeah. And Phil may want to explain in a little more detail how that works, that the government gives these companies a pot of money and gives them a certain number of patients to take care of, thinking they'll do it more efficiently. United Healthcare has now been indicted for fraud, which I'm sure you heard about, and I used to see this firsthand. My patients would get these letters from United Health that they were sending nurses out to do a well exam. And I kept thinking, well, why are they doing well exams? I do well exams. And then I don't think they charged them. In fact, they gave them a gift card. Yeah, they gave them a gift card if they would consent to it. So what they would do is they would go down there and put down every possible diagnosis, whether their regular doctor had claimed the diagnosis or not.
Yeah.
Many times they were wrong, but because United Healthcare got more money per diagnosis, they would just buff their problem list essentially and put 10 more problems on. And they did it in the nursing home. I would see these nurses walking around and say, and I was the medical director. I said, what are you doing? And they said, oh, we're just doing charting. Well, they were buffing the charts to put more problems on so that when they billed, they could get more money. And it turns out a lot of the diagnoses were incorrect. They never asked the doctors to confirm it. They just put them down. So I'm sorry, I didn't mean to give another talk.
No,
You just lit a fire.
you know, I've talked about all of those things before, and tried to keep it a little leaner, but I'm really glad for your perspective.
But just to follow up on that, because you touched on the thing that I wanted to ask. Bill and you were both very scathing about the Medicare Advantage. What percentage of people opt for the Plan C versus the supplemental? Do you happen to know that? Because I asked that because I take the supplemental. I'm very happy with the medical insurance that I have.
Yeah.
You have
So,
No, I do not have.
Oh, okay. That's why you're happy.
I have.
Yeah.
Yeah, that's
so
right.
it's a really good question, and there's so just to be a little bit more clear, so if you get sort of straight or traditional Medicare Part A and B, that covers a lot, but it doesn't cover everything. And so people have to get supplemental insurance on top of that to make up what Medicare doesn't cover. Now, we could talk about that separately. This is like, why would we create a system that doesn't actually do what it should, and you got to buy additional insurance? But okay, that's annoying. And then separately, you get the Medicare Advantage Part C program. Now, more than 50% of people on Medicare have Medicare Advantage plans, so that Medicare Part C. And there's lots of reasons that people pick them. One is it's less expensive for them out of pocket, and that's taking a risk, right? Because if it covers less and it creates more barriers to you getting care and the outcomes are worse, you better just hope you don't need it, right? Because that's when that becomes more clear. And people are sometimes wooed by the hearing, vision, dental benefits, even though they don't actually help you all that much. So, there's lots of, but for some people, when they're on a fixed income or a limited income, that's the only option that they have. And that's a shame, right? Like that shouldn't be the way that we've created things in this country. So yeah, and many people are happy with their insurance until they need it. And then that's when they become a lot less happy with it. But yeah, thank you for the question. I see another question.
Yeah, I have my own theories about why people resist any changes in our health system. One of which is fear of government. And I wonder, Bernie Sanders was trying to get elected based on this idea of a single payer system, which is basically the government takes over paying everything. And there seemed to be some resistance. And I wondered, did they do any surveys around why people were resistant to the idea of a single payer system?
Oh, that is a really good question. So there's a couple of different ways to answer it. First, when they have surveyed docs and when they've surveyed people, the majority of people are actually support this kind of a system. And so, but why don't people like it? So if you ask doctors why they don't want it, it's typically the doctors that are in the higher reimbursing specialties. And that's because they fear that this is going to impact their ability to practice. Either it's going to create more constraints or they're not going to be able to make as much. Right now we reimburse surgeons and cardiologists and gastroenterologists, people that do procedures at much higher rates than we do primary care. And so primary care doctors will stand to benefit, specialists maybe not. So that's certainly one objection that doctors raise. I think another objection that doctors raise is it sort of relates to, I think there's fear of change. We've got a system right now. I'm used to it. I don't necessarily want to change. Also, how can we possibly, there's the notion that the government can't do anything efficiently or effectively. And I think that that's sort of a false trope. I mean, when you look at Medicare, 98 cents of every dollar that goes into the Medicare trust fund through our taxes comes back out to pay for healthcare. Whereas if you're a private insurance company, it's maybe 85 cents because the other 15 cents of every dollar that they take in goes to profits and overhead and administrative costs, right? So if you're looking at efficiency as simply what bang do you get for the dollar that you spend, Medicare blows them out of the water. But people also don't like some of the problems that Medicare has now, the paperwork burdens. Some of that's driven by Medicare. And I would argue we got to get rid of all of that, right? If we want to create a government run system. There's of course the question too that people have of, well, this will mean a rise in our taxes. Yes, but it will mean nobody has to pay insurance premiums anymore, right? It means that if you start a small business, you no longer have to figure out how to provide insurance for your employees, which nobody starts a small business because they want to provide health insurance for people. They do it because they, want to make whatever they want to make in their small business, right? So and then perhaps the most insidious, person that doesn't want it is not the person at all, but the private insurance industry, right? Because it means the end of a lucrative business model for them. So they're going to fight this financially in every way that they possibly can.
Well, there are more of us than
There are. I appreciate that.
Why are we still ineffectual?
I know. I agree. Other thoughts or questions, and then I want to dive into some of the things that I think are a little bit more thought-provoking, sort of from a Christian perspective. Not seeing any or hearing. Yeah, what do we make of all of this? And I guess I would argue that we should be caring for people in need, right? And so, one question that often comes up is, does everybody that lives in the United States, do they all deserve health care regardless of race or gender or citizenship? And and if I look at this through a Christian lens, honestly, I would look at this through a human lens, right? Like, I just kind of think that, we've said in this country that the government should do things like maintain roads and have fire departments to come and put out fires if your house catches on fire, right? I'm not sure that I know why healthcare should be any different because, having a road to drive on to get from one place to another isn't, it's just something that we sort of expect out of the government. We have to think about where we draw the line on services like that. And, we've created a safety net with things like Medicaid and Medicare, for people that, Medicare was created because in those days, if you were over 65, you just weren't working. And if you didn't work, you didn't have access to health insurance. And therefore, things just got real bad when you got sick. That's why Medicare was created. Medicaid was created at the same time because we also recognize that some people simply don't have enough money for whatever reason. And they shouldn't also be simply left to die out on the street with their chronic diseases. And so, I think another argument, of course, is that all the other developed countries in this world have figured out how to provide healthcare for their citizens. And we simply have resisted that call. So I don't know. To me, I would make the argument that from a theological standpoint, it does make sense. And I don't know where you can draw the line, right? We'll only help these people, but not those people. The second you start trying to do that, you create an exclusivity. And I don't think that Christianity is about exclusivity, right? At a fundamental level, I don't think that makes sense. And so, this is a more provocative one. Is capitalism anti-Christian? And I'm sure that not everybody is necessarily going to agree with me on this, but to me, at least within our healthcare system, all of these things that we've talked about, they don't seem to be consistent with what I would consider Christian tenets, and again, I come back to this idea that we shouldn't let value determine whether or not something gets covered. We should let our values dictate that, and what is the fact that, really literally thousands of people die every year for lack of health care coverage? What does that say about us? That says that we're not valuing those lives and we're not trying to find a solution for them. And I don't know if any of this is resonating for any of you, or if you want to argue with me about, about capitalism being anti-Christian. I think we can find examples of that in the Bible, as well. But that's perhaps a more loose interpretation of things. So I'll wonder what folks think about, values and how we look at everything that we're seeing right now through that framework.
So I'll say this, I'm a capitalist, and I believe in capitalism as an American system. I think it works well in a democracy. I don't think healthcare should be capital. I think that's, see, simple solution.
There you go.
I'm sorry.
Well,
Got the drop.
But look, we are all invested in capitalism in one way or another.
Yeah.
Retirement programs, our investments are all capitalism based. So it's not like we should get rid of capitalism because we're all impoverished. The question is, how do we manage capitalism so that its best advantages come to us and its liabilities are reduced? And I think that's a matter of government policy, and that gets into a whole other question that I'm sure you're not prepared to answer, nor am I. But it's a problem that we need to grapple with in a much more fundamental and thoughtful way as Christians and as capitalists both.
Yeah. Well said.
I think that's right. I wasn't necessarily proposing to throw out all of capitalism, but I'd certainly agree that within the healthcare system, that problem that there must be losers. I don't know. I don't think we want to have losers in the healthcare system, and I don't want to see competition, driving people's healthcare. I just worry about that, right? And I've seen the problems that creates. So I agree with you. It becomes a matter of policy. And I struggle a little bit too because I hear a lot of talk right now that the current administration is trying to bring us back to being more of a Christian nation, but I just feel like the decisions are not consistent with Christian values. And that I struggle a little bit with too, because I worry now that Christian values the concept has been co-opted or perverted or redefined to meet somebody else's needs. And that that I think also makes it problematic for the rest of us who think of ourselves as Christians, but are like, wait a minute, this is not the Christianity that I think of, right? And I think that's hard when we're looking at the decisions that our government is making or the policies that they're pushing forward.
I firmly believe that everyone deserves health care. And, places like the Zoo Wall Clinic, why do we have more clinics like that? How come they're not funded? I used to help run a women's health care in Dover, volunteer. And we never asked, who's your insurance? Where are you from? Are you a citizen? And I think that we need to move more towards that, giving health care. So where do we get the money for clinics like Zoo Wall? They're state funded, they're government funded. That's all going to go away.
Yeah, I know it's scary. I mean, where that money comes from, right? Like, on the one hand, we spend so much excess compared to other countries that, by one analysis, if we simply redirected all of the spending that we do in this country to a government single payer rather than away from sort of health insurance premiums, we actually spend enough to cover everybody for everything that everybody needs without copays, without deductibles. All your benefits would be covered if it were funneled through a single government, based insurance company. And that, that to me, like that's what I would like to see. And that to me seems to resonate more consistently with what I think of our the values that we have. But again, it's actually a massive undertaking to redirect that transfer of finances away from the private sector and into the public sector. And that raises concern for people, and I think rightfully so. But I think that, I think we have an obligation. As a physician, I think we have an obligation to push for the healthcare system that I think everybody deserves and leaves nobody behind. We have 27 million people uninsured in this country, and that means that we probably have around 30,000 deaths in this country that can simply be attributed to being uninsured, at least based on some studies, and like that's like 30,000 people dying for lack of insurance. That is a lot of people dying, many more that die than from, diseases that we otherwise spend a lot of time focusing on. And so, we have chosen as a country not to try and fix that problem. And I think that set of priorities is off. And I think that we need to be finding people, electing people, pushing our legislators, our politicians to, I don't know, to be taking care of people, and in a way that is humane. Yes, sir.
I'm sorry to ask all these questions, but as you're, by the way, this has been great. You have put together a lot of information, which in one package confirms a lot of what we suspected and provides us with basic information we can go off with and have a great deal of confidence in. So thank you. It also has succeeded in depressing me, but I will say this. There are a number of messages going out, a number of appeals going out that are all over the place. So we're going to save democracy, or we're going to have a fair taxation policy, or we're going to have home manufacturing, U.S. manufacturing, get it away from the international folks, all of which, of course, have some merit. But I'm wondering whether a single message around healthcare could fix a lot of it. That could be the primary message that politicians carry forward. If we fix healthcare, the following things occur, all of which touch each and every one of the things I mentioned.
Yeah, no, I couldn't agree more. I mean, and honestly, this is fixing how to fix healthcare is you can tailor it to your audience, right? I can give this talk to business leaders. I can give this talk to politicians. I can give this talk to to physicians, but also to people in the community, and it's different every time. And I absolutely agree that if we fixed healthcare, so much would be better, right? Businesses in this country could focus on their business and not on how to whether or not or how to pay for healthcare, right? And I think that when you have a healthier workforce, people become more productive. If that's one measure that you want to look at, not having people die like seems like a good thing. And, and so, I couldn't agree more that could be an overwhelming message. I think it very much was for Bernie Sanders. I think that he's not going to be at this for much longer. I think he's somewhere in his 80s at this point. So, I don't know what the future holds. And I also, and I come back to that concept of our values and wonder if how we frame this stuff to people. Do you frame it from a sort of humanistic perspective or from a Christian perspective, or, what do we believe the world should be like, and try and work towards that goal. So I love the idea of leading with that. I think that's a thoughtful way to do things, but recognize that there are people that don't want the system fixed, and they have a lot of money.
Well,
Thanks for getting up early.
Oh, no problem. Any other thoughts or concerns, or I don't want to take too much more of your time.
thank you.
Well, you're very welcome. You're very Yeah, I appreciate it. This was fun, and it got me thinking a little bit differently about some of this too. And it's a little bit like a great big civics lesson. How do we think about the country that we want, the world that we want? And to me, for many of us that are in medicine right now or in science, we're sort of running scared because we're seeing the entire system that we thought was foundational, completely gutted, and we're afraid for the future, and we're afraid for our families and for our health, and I don't I'm not happy that we're in this moment, but I think it does give us a chance to sort of say, okay, what do we value? And what is going to be the phoenix that rises from the ashes of the chaos that we see right now? And my hope is that we can start to envision a future that I think actually does make sense for people and is consistent with what we believe in.
Thank you.
Thank you so much,
Thank
Phil. I think that people like you are giving us hope, and I so appreciate you for being here with us. So thank you.
Get some sleep.
Yeah.
You're very welcome, and thank you all. Take care. Be nice to my dad.
Please. Friends, just so you know, next week we're back at our 8:45 slot, and Bill Cunningham is going to be with us, which will be wonderful. He's going to do a special Memorial Day program, so hopefully you won't be out of town and will be able to join us for that. So thank you for being here, and we'll see. Oh, he popped up.
Thank you.